This is another case like that. They need anti-chamber tap and anti-chamber voriconazole for the cure of this condition. And this is another one, non-healing corneal ulcer infiltrated. This is very typical of neurotropic ulcer, anesthetic cornea. Anesthetic cornea, where there is corneal sensation will be totally absent. So this only treatment is torsorrhaphy, nothing else works. We have to convince the patient sometimes we do bilateral torsorrhaphy also. And if you don't do it, they will become like that. They just melts off and perforates. And atheromatous ulcer, another very nice one. They break down. Patient says, it happens once in 3 years, 4 years. Then I go and they give lubricants, it heals. But every time it breaks down, some amount of epithelium, some amount of stroma will disappear. So after 4 or 5 episodes, it will perforate. If you think the previous surgeon has just treated with lubricants and antibiotics is fine, I also do that, and patients insist on that. If you do that, you will be in trouble. The 6th time, 7th time, if you are treating, it just perforates. And this is the one-eyed patient we had, and some SA sectorectomy, aphakic, and atheromatous ulcer. It took almost 2 or 3 days for him to convince that we had to do a lamellar patch graft for this patient. And another one, a patient like this comes, generally we think it's not solvable, a young kid, and anticephaloma, perforated ulcer with anticephaloma. You just leave it out, but don't worry, just go ahead and do grafts. You got to. This is a photograph 10 years after surgery. The patient had retained eye and he had around 5/60, 6/60 vision, and this is after therapeutic grafting. So never hesitate to do a therapeutic grafting in any stage of corneal ulcer, even if it's a full anticephaloma or whatever maybe. This is another patient, more than 2 months treated. It's fine, 1 month, 2 months. Then you just, what's the treatment, you got it. Then he gave so much. So many papers he is filing. So the moment you see it, you don't think that you are going to do some miracle or something like that. Just straight away go for drugs, doesn't work. You tell the patient, drugs doesn't work. They tried all the drugs available in ophthalmology. Just go ahead with surgery. Here's a therapeutic graft. Or we did this acanthamoeba, we did a lamellar therapeutic graft. He's doing beautiful, very nice recovery of the vision. This is another example where patient is partially treated. He went to a doctor and treated and is going on treatment and it's healing, actually it's healing. But patient wants second opinion, why so many days I am having trouble. So they come to you, then you are in trouble, whether to tell the same treatment continue or you want to change it. That is the biggest mistake we did. We had to assess the one. Once this is all clear, margins healed, here still there is an ulcer. So it is responding to treatment. So you tell them it's responding, you are, don't change, please don't change any treatment, any not even a single, another brand also, please don't change, just let him continue. Thank you very much.
Thank you, sir, for the wonderful presentation. Next, I invite Dr. Gopal, one of the most dynamic retinal surgeons in India, and he'll be speaking on mistakes in management of medical retinal diseases.
Can we move on? Slides. Yeah. I want to start telling that experience is simply the name we give our mistakes. So the more experienced you become, it means the more mistakes you've committed, the more the fingers we have burnt. So this is not moving. You are moving? Okay. So mistakes, broadly we can divide into mistakes in diagnosis or mistakes in interpreting the investigations. Generally in medical retina we may be giving drugs like intravitreal injections, etc. In drugs, dose, duration of treatment, you can make mistakes. You have laser mistakes, and obviously the biggest mistakes are in counseling the patient. This is not moving. Can you come to the next slide? So mistakes in diagnosis, you can make certain changes. Next slide. Age-related macular degeneration, one thing we have to always make sure in our mind is whether this is active disease, whether this is inactive disease. Whereas the one in the right side is actually active, and there is a lot of choroidal neovascularization, active bleed, whereas here on the other side you can see scar. So a fluorescent angiography can typically show that, and OCT can also supplement our diagnosis. So sometimes what happens is a youngish, about 50-year-old person walks in with a lesion like this, who is a diabetic, you may be thinking that it is diabetic retinopathy, etc., but there are no microaneurysms. If you carefully look at this, there are some changes here which may suggest that it is outer retinal disease along with all these hard exudates. So without microaneurysms, generally think in terms of PCV or CNV. Here it was a case of choroidal neovascular membrane with retinal pigment epithelial lift and type 1 neovascularization below. Again, hard exudates here. There is one small lesion here. This is actually an intraretinal bleed. So this was again a choroidal neovascular membrane, and this choroidal neovascular membrane with bleed, it was not an AMD but it was a PCV, and you can see the changes between 2012 to 2017, how beautifully it has resolved. But if you did not make a diagnosis of PCV, probably you would continue to keep on injecting thinking that it is choroidal neovascularization. If you diagnose that it is PCV, then we will probably do a laser or a photodynamic therapy to stop the injections. Branch retinal vein occlusion, this is a very typical branch retinal vein occlusion, but sometimes it may not come as typical as this. So sometimes there may be only hard exudates with a little bit of abnormalities in the blood vessels, especially since the BRVO had occurred some time back. And again, only hard exudates here. Hard exudates with some amount of hemorrhage. So in these cases where a long time has passed between the initial presentation versus when the patient is presenting to us, we have to take subtle cues to actually get on to the diagnosis. Like you have to look at the caliber of blood vessels. Probably you can look at one of the vessels which are occluded, etc. That is often true in an old, this is like hard exudates only in one particular territory, superior temporal territory only. You should be thinking more in terms of branch retinal vein occlusion. But can you think that this is branch retinal vein occlusion? This whole area exudates are there, but you can see that the vessel is only involved here. That is how you would make a diagnosis. So this is significantly blocked here. A central retinal vein occlusion also initially will present very dramatically with a tomato ketchup appearance, but when you are later in presentation, after 6 months, after 1 year, the vision is only 6/60, patient is coming for a cataract surgery without a history of a sudden loss of vision previously, then there is a little bit of a problem in diagnosis. Tributary venous occlusions are often very, very difficult to diagnose once they are past about 3 or 4 months. Idiopathic juxtafoveal telangiectasia. These are small Muller degenerations which occur close to the fovea, and it's a very, very slowly progressive chronic disorder. And many a time these will be treated like choroidal neovascularization or diabetic macular edema and given injections for the leakage, which is not true. Similarly is the case of chronic CSR, where if you can see something like this, track sign, then if it is a chronic CSR, many a time it is mistaken to be something like a choroidal neovascularization treated. Always look at blood pressures whenever the patient comes with something like this. These are attenuated blood vessels, hard exudates, cotton wool spots, and disc edema. This is a grade 4 hypertensive retinopathy. Unfortunately, most of us ophthalmologists, even though we may do refraction and a lot of complicated tests like OCT, we may fail to take a blood pressure, and that will be the nemesis of that particular patient's life also. Hypertensive retinopathy may come with macular star like this or soft exudates. Macroaneurysm is another thing. You can see that here hanging, it's a higher magnified picture. Hanging around this particular vessel is a macroaneurysm, and around the macroaneurysm there are hard exudates. This, if you keep on injecting, there is no benefit. You have to basically laser this and annihilate it. Radiation maculopathy, there may have been history of a cancer in the head and neck region, irradiated, which the patient did not tell you, and the patient comes with this soft exudates all over the retina with some decrease of vision and ischemia. You may be thinking about an alternate diagnosis, but radiation retinopathy or maculopathy should be kept in mind. Always in posterior uveitis, think about optic neuritis as well. It is not just the macula which causes decrease of vision, it is the optic nerve also. So whenever there is a, here you have cystoid macular edema in this posterior uveitis, but you can also see significant disc leak. So the decrease in vision may not be proportional to the macular edema, but it may be caused by optic nerve pathology as well. And this is a neovascularization. Toxoplasma, when you see a typical headlight in the fog appearance, no problems, you will make a diagnosis of toxoplasma. But if the number of vitreous cells are very less, if the vitreous haze is very mild, then you may think in terms of a retinal artery occlusion, especially if it is a larger area, and if there is a chyleriasis plaque, which is an arterial plaque which is near the toxoplasma scar. So if you see something like that, you may consider. I made a mistake last 2 weeks back. One patient came with toxoplasma. It did not have a lot of vitreous haze, and there was a chyleriasis plaque. So there was a arterial block sort of a thing. So I thought it was a retinal occlusion, and I gave the investigations for procoagulative workup. But fortunately, I had also given a toxoplasma. IgG came to be 600. Neuroretinitis, again I wanted to emphasize optic nerve toxicity. These are some of the other diseases which we may confuse. Leukemia and anemia, you can see multiple small bleeds. You should always look at blood pounds. Sometimes AION papillopathy can also present with that. This is a vitreous hemorrhage in which this is dengue hemorrhagic fever, and this was in a liver failure. Dose or drug, Avastin, there can be a lot of mistakes right from the procurement to the storage to the transport to the giving technique, etc., etc. I'm not. That's instruction goes by itself. But recent anti-VEGF should not be given in stroke and heart attack, maybe in 3 months. And IVTO should not be given in triamcinolone should not be given in glaucoma. Reduced frequency of injection so that the patient is happy and keeps on following up is a very important reason why the patient may not be improving in vision. And failure to revise the diagnosis, that is a very important thing. If after 3 or 4 injections, if the patient is not improving, you should think about redoing a fluorescent imaging, etc. and all. So this patient had a nephropathy, multiple soft exudates. One may want to just follow up this patient because macula is okay, but this patient had proliferative diabetic retinopathy. This patient had again systemic issues. We were not able to convince him to treat. Look at what happened after 6 months of non-treatment. You can see that the vision dropped to 6/60 in this eye, and this eye also is not doing well. Now this is a patient in whom you need not keep on injecting. This is just about peripheral laser. You can just do some laser treatment, etc. This is a patient right from 2007 till 2017 we have been following up. Till this stage, I had given anti-VEGF. He had an inflammatory mediated macular edema. Once I shifted into Osurdex, you can see within that single injection, you can see how clearly it became. That is how, when one particular thing fails, you think back again why it is failing and try to find out why. This is a small little bit of cataract and nuclear sclerosis, and this was the retina looking all right, 6/9 parts, a cataract surgery done. 6 months later, the patient comes with a bleed. There was a proliferative diabetic retinopathy underlying it. It was an uncomplicated cataract surgery. This is similar lesion. This is a fluorescent which was done before, and this is a fluorescent done after cataract surgery. You can see the progression. So always counsel the patients regarding all this. These are all OCT scans of patients, again and again follow-up scans of these patients. Many times you can see that it comes down, then it goes up. Many times the patient loses follow-up. Sometimes we will, for the patient's benefit, say that we can reduce the frequency of injection. Then you can see that these sawtooth thing will occur. Sometimes you should think about optic nerve papillopathy, the papillopathy, diabetic papillopathy, when there is a traction. NVG, always never miss NVI. Pitfalls in practice, sometimes patients may be in poor diabetic control. The economics of injections may not allow us to inject, so we may do some things like that. There are no bystanders sometimes. So sometimes the patient is all mentally fatigued, we cannot talk. Sometimes there are coexisting illness like foot infections, stroke, heart attack, renal failure. Unless you ask, the patient will not tell. Because we are ophthalmologists and they will think, what is the point in talking to him about renal disease? So the dialogue with the patient is very important. Educate patients, DME booklets or other medical retina booklets, explain about long-term treatment, multi-pronged approach, and DR risk calculator. Thank you very much. A fool thinks himself to be wise, but a wise man knows himself to be a fool. Thank you.
Thank you, Dr. Gopal Pillai. It's nicely shown what is the common problems we may face in our practice, even for non-retinal people. Questions? Yeah, any questions? He has to go to other session. If you have any specific questions, if you ask him, then he will answer. Then he has to go for some other session. You're going,
Yes, sir.
Yes, sir. Yeah.
Video assisted skill transfer is happening on the other session.
Yeah. Okay. Okay. Then next, our next speaker is Dr. R.D. Ravindran, fondly called by all of us as Dr. RDR. As you know, He heads the Arvind Eye Care system and the hospitals, and he stays in Madurai. And he got extensive knowledge in both posterior and anterior segment. Now he's going to talk on mistakes in the IOL selection and cataract surgery techniques. So as they're doing very large volume surgery, I told him specifically to collect the data and see what is practically is happening rather than hypothetical models of mistake. Okay.
Yeah, thanks, Dr. J.K. Yeah, I'm going to talk more about some of the non-clinical things. You heard a lot of clinical things now. We'll see how some of the non-clinical areas and non-clinical issues also very important. I'm going to talk about what mistakes happen in cataract surgery, and basically I'm going to just only look at this IOL implantation part of it because of the time. So if you look at the modern cataract surgery, it's very complex. If you look at the cataract surgery, we have today 3 options. You have small incision, you have phaco, we have plaques, and they all come at a different financial packages. And then we have different type of IOL selection, at least in our institution. We have 6 or more different type of IOLs at different points, and then the power varies from 10 diopters to about minus 10 to 30 diopters. And we have a lot of power calculation formulas. Different eyes need a different type of a formula. Not only you should know how to select it, and there are also special situations. And again, we have different biometry equipments. Even the same company, one model varies from the other model, and if you're really not aware of what are the complexities, you tend to make mistakes. And we are going to, and in addition to that, we have also the human beings, us, who make other mistakes. And this is probably only paper I know which has been published on the surgical errors or mistakes which have happened. This is a paper which was published in Archives of Ophthalmology, wherein they reported these kind of errors of a wrong IOL implant, wrong eye surgery, wrong block, wrong patient, of about 62 cases in about 900,000 surgeries. This is all reported from one complex. They also added another about 44 cases from another program. So totally there are about 106 cases. So if you look at this 106 cases which went wrong, there are about 67 cases were about only IOLs, wrong implants. These all have been reported from New York and also from another state in America, where the way they work, it's more individualized. They take all the care to make sure that such things don't happen. But in spite of all that, this is what has happened, and still it continues to happen in many of the countries where we interact with them specifically on this particular area. So I just only will be highlighting how things go wrong in our own institution. And I'll just bring out about 5-6 cases I just want to share with you. So this is one in our hospital in a camp. We had 2 patients with the same name, Kalai. So they had the surgery needed for the same eye, and they are posted in the same OT. So one patient needed an 18.5 diopter, other patient needed 26.5 diopter. The 18.5 diopter patient needed the culture report. So the case sheet was taken away for getting the report to the microbiology lab. So when the called the Kalai, with the other case sheet, actually the sister had the case sheet. So she called, instead of this patient, the 26.5 diopter patient, the 18.5 diopter patient came. And then we operated, without realizing the mistake, it was operated. This 18.5 diopter patient got a 26.5 diopter IOL. Then what happened to this 26.5 diopter? When the culture report came, this patient, looked at the case sheet, and she saw the consent form with the thumb impression. She said, no, I have not put a thumb impression, I have always signed. So this is not my case sheet. That is when we realized a mistake. Then we got the correct case sheet, and that patient got a 26.5 diopter, and the other patient we had to take up for a explantation and implant a new IOL on the next day. So this is how, as human beings, if we don't actually check the patient's name, medical record number, all that, now we have changed a lot of things. We have wristbands, many processes to make sure that this kind of errors don't happen. So not only you have to put in place certain pre-operative processes, we have to check that in the operating room as well, because now the scan reports are generated from the machine separately. It becomes part of the case sheet. Now we can get a same report, a different report attached to a different case sheet. That mix-up also can happen. It doesn't mean that that case record, a case file will have all the records belonging to the same patient. We cannot take that assumption, and we have to make sure that all that records which are different records belong to the same patient in a case file. So all that multiple points we have to check it. The second case is about an uneventful cataract surgery with an implantation of IOL. Nothing went wrong. But post-operatively, when the patient came, the patient had only 2/60 and it had about -9 diopter IOL. Then we looked at whether we have put the correct IOL. We have put the correct IOL. It shows that, can you read? This is about, what does it show? 29. So we have put a 29 diopter IOL. Then only we realized when we closely looked at it, it was not 29, it was 20 diopter. What mistake has happened is the doctor has put a seal. We have to know, whichever doctor does a preliminary examination, they put a seal. The end of that seal is here. That made the 20 into 29. And that is how that mistake happened. So this is something small, can also lead to mistakes. Probably that means we have to make sure that they don't put a seal at that particular place. Now we have a different area where they do it. So we have to change, and then the patient got back about 612 vision. So this is the third case. The patient had uneventful surgery with a 17.5 diopter. Post-operatively had only 618 vision. When you looked at the refraction, it was like plus 1.5, almost like about plus 2.5 diopter error, hypermetropic. Then we looked at the thing. This all has happened after EMR. EMR, we have some challenges. So this patient actually had a biometry done on 20th. We found that this patient needed 24 diopter. But on the day of admission, again the patient got another EMR done. Then we found that we have, you see this says LensStar, but actually we use the LensStar machine for the data entry. We have an IOL Master 700, which is very faster. We can do it much quicker also. So we use it, and then use the LensStar for the transcribing. We put the data from IOL Master 700 into this LensStar, and when they did that transcription, this error has happened, then that is what we noticed. So then we went to the EMR, we saw this data being done. There is no way within our EMR, as we are evolving, we don't have a way of looking at this and this at the same time. And we have made something into the EMR now to reflect this reality also. So as you can see here, it was 17.5, we have to put a 24 diopter, and then the patient improved to about 6.6. So this is again something can happen. These are all intended mistakes, but they happen because of the way we structure workflow. This is again another patient who's got a -9 diopter. This is here what transcription error happens, similar error. As we do it in the EMR, when they saw 24.14, they typed it as 21.14. So there is a difference about 3 millimeter that leads to about this -9, and which again we had to go back and do an explantation and the thing. So this is one patient. It's not our patient. This patient came to us. He was a 40-year-old myope, high myope. He had a bilateral clear lens extraction done somewhere else. He had showed that he had a +1 diopter implanted because that was the calculated power. But if you look at the post-operative refraction, the right eye had a +3 diopter. Okay, the left eye had -3 diopter. But what the patient says that they had only a +1 diopter implanted. He had it in his discharge summary. So then we were very curious why this has happened. We had different powers in both the eyes. Okay, then we did an IOL exchange. We calculated again the +1 came. So we implanted +1. Post-operatively, patient was symmetropic. So we knew that the required IOL power was +1, whatever they have calculated. Then we have taken out the lens in total, and then we found that IOL was only -3 diopter. Okay, so that was a mistake. The IOL that was supplied to the doctor and was implanted was wrong. And then why this has happened in the other eye? The other eye, the calculation was wrong. because the required IOL power in the other eye was -6, where they've implanted -3 in that eye also. That is made into a +3 error in the other eye. So you cannot, sometimes it can be the manufacturing error also. Sometimes you also seen what is reflected on the cartoon outside is not the same inside. The inside label will be different from the outside label, which also you need to check. So all these things can happen. And again, also we have had instances where the silicone oil mode was not used in the patients with silicone oil. All of you know, when you have a silicone oil, the ultrasound travels slower, and then the axial length always shows up higher, and then we have to do that correction. If you don't do the correction, now it's all part of the machine, so if you don't use that mode, it can happen. And once, as we are making the transition to immersion mode, the people did the immersion mode but with a contact mode on the ultrasound. That again kind of produced error where patient had we put in higher power lens and the patient had myopic refractive error. So this is another case. The toric IOLs bring in a lot more complexity. So here is a patient who had about 2.25 diopter astigmatism. So he had a 44.25 at 90 degree and then 46.5 at 180 degree. So as you all can see, he had an against the rule astigmatism of 2.25 diopter. So the patient got a IOL, and then when the patient came for follow-up, then we found he's got a -290. The thing. Because the pupil was very small, we could not see the axis. Ideally, we should have put the correcting thing at axis at 180 degree, which was placed in 90 degree. When we did the eye trace, we were able to find it. Then we looked into the case sheet, into the IOL calculation, toric calculator. Then we found the sister has actually, should be 44.25, 90 has become 44.25, 180. So there was a transcription error when you do it into the toric IOL calculator. Once after seeing all these things, we also have come up with a separate checklist for the toric. Because this is only the changing of the axis, we didn't have to explain, we just did the repositioning, redialing of the IOL, and the patient was able to get a good vision, the 6/6 uncorrected vision. The patient was very happy. So there are several ways things can go wrong. And again, one instance, instead of entering the SIA as 0.5 diopter, if you see this, somewhere we have to enter the SIA. So instead of entering SIA of 0.5, they entered 5 diopter. Okay, that means a totally different type of an IOL we had implanted, which I had to remove. And again, the other challenges are errors in reference marking, post-operative IOL rotation. It is now, there's a recent paper, most of the IOLs rotate in the first 6 hours. So initially, after surgery, if you're doing a toric IOL, you must ask the patient to take adequate rest, not read, watch TV at that point of time. Even all the movements have to be gentle. So just to conclude, the other point is about putting the IOL, one, especially a single piece IOL, putting it in the sulcus, even if one is in the bag, one is in the sulcus, can cause erosion of the iris, and then you can have uveitis, glaucoma, hyphema syndrome. So what I've tried to show in this short time is that we can have transcription error, we can have the wrong patient's biometry data entered into, especially if you're using an EMR, and then wrong IOL selected. Sometimes the nurses may bring a wrong IOL into the operating room, and all the errors associated with EMR and also with the toric calculation. And we all know that if you are really talking about quality, safety is the most important thing, which means we don't harm the patient. It means we operate on the correct patient, the correct site, and we do the correct procedure. And what is applicable within Aravind or within my institution may not be applicable to your institution, because all these errors are related to the workflow, how you structure the patient flow, how you do, how you train your staff, and how you place the equipments and all that. That is what makes it. So each individuals or institutions have to develop their own protocols. Basic thing is you have to reduce the complexity, you have to develop reliable processes, and again, whatever work is done, somebody must check it at least once or twice before the patient goes for the surgery. and just to conclude that, we cannot just rely on individuals. Sometimes, we think, this person is very reliable, but the systems are also very, very important if you have to completely, eliminate all these man-made errors. Thank you.
Thank you, sir, for the wonderful presentation. So, how do you check the power of the IOL that you have explanted? Send it to the computer.
We use the oral lab to look at it.
Okay.
So this particular case, we just took it out intact. We didn't cut it and remove it.
Okay. Thank you, sir. Next, we have Dr. Saikumar. Is one of the real high-volume cataract and glaucoma surgeons in Kerala, and he'll be speaking on mistakes in diagnosis and management of glaucoma.
Thanks a lot, Srini, for having me in this course. I am basically sticking to glaucoma diagnosis because in this short time it's difficult to cover glaucoma management also, and with Srini's permission I'll be basically on glaucoma diagnosis. The commonest mistake that one tends to make in general practice is to look at the optic disc and mention the cup disc ratio. I'm not saying that the cup disc ratio should not be mentioned, but then it has to be qualified. If you're looking at the cup disc ratio from a glaucoma perspective, it has to be qualified whether there is any local defects, whether there is a notch, any RNFL defect is there. So only then it becomes relevant as far as glaucoma is concerned. Just this is a very, very common picture you might have all seen. Just to mention that in a small size disc, a medium size disc and the large size disc, the amount of neural tissue in all these three is absolutely the same. It is just the size of the optic disc that makes appear that this particular disc is this cup is much larger than this. Okay? So the neural rim is what is important in glaucoma, not the size of the cup. So we are worried about whether the neural rim is damaged or not. We are not worried about the actual size of the cup. Although they do correlate in specific instances, we are not worried about them. And for that, the disc damage likelihood scale, or the DDLS, gives you a significant input, and it really tells you how you have to specifically focus on the neural rim and not on the cup. So the lesson we learn from this is that just the value of a CDR does not convey the actual damage to the optic nerve head. And just to mention, a cup disc ratio of 0.4 with a localized notch is a typical glaucoma in a small disc, while a cup disc ratio of 0.8 with a uniform neuroretinal rim in a large size disc is normal. Don't miss out on retinal nerve fiber layer defects. You have to specifically look for them, and if you can find out an RNFL defect, it almost always tells you that this is likely to be glaucoma, because studies have shown that true RNFL defects in a normal population is less than 3%. So if you have an RNFL defect, it is most likely to be due to glaucoma. These are fine, silvery striations that you see, and you can actually compare in a red-free picture. You can compare the color, the dark color of the fovea with the dark color of the RNFL defect, and that is one easy way to find out whether the patient has got a retinal nerve fiber layer defect. Now, what looks like a typical field defect may not be always due to glaucoma. Now, if you look at this particular field, the first diagnosis is that this patient has got a typical arcuate scotoma, which is most likely due to be glaucoma. But this patient has got a tilted disc syndrome. This is something which, the errors that we make when you just look at the field and make a diagnosis. But my point is not that. My point is that this particular patient with this tilted disc can also have glaucoma. So this is something, again, you have to be a bit more careful. So when you find a tilted disc, you find a typical nerve fiber layer defect, a field defect on perimetry, you just dismiss it and say, oh no, this is due to tilted disc. No, this particular patient can also develop glaucoma. So, but unfortunately, you can't use the optic nerve as an indicator here. You have to look at other things like the corneal thickness, the intraocular pressure, the family history, and the other risk factors. One or two other, common things that can happen. These two are colobomas of the optic nerve head. You find that more of the disc is damaged. It's more like an excavation rather than a localized notch. If you look very carefully at these optic nerve heads, you find that these are excavations with large extensive retinal nerve fiber layer defects here, which is usually not common in glaucoma, and then you find that the other rim or the other pole is nearly normal. So these are optic nerve head colobomas or small defects, which again gives you very typical field defects. This is another patient with coloboma slightly away from the disc, and they all show typical field defects like glaucoma. So examination of the optic nerve head very, very carefully is extremely important so that you don't miss out on a glaucoma and you also don't make a misdiagnosis of glaucoma. So the lesson learned here is that the optic disc is a great mimicker, and you have to look at it very, very carefully. And as I mentioned before, such patients can also develop glaucoma, so you have to look at other factors. Another thing that is commonly missed out in glaucoma practice is the presence of disc hemorrhage. We all know that splinter hemorrhages in the optic disc are quite common in glaucomatous damage. Statistics tells us that it's more common in normal tension glaucoma, but we also find it quite often in patients already on treatment with typical open-angle glaucoma. The most important thing is that they tend to come and go. So when you examine that particular patient, the disc hemorrhage may not be there, but if you see a disc hemorrhage during your examination, it is one of the indicators that there is something going on, some vascular instability is going on at the level of the optic nerve head, and the treatment that the patient is receiving is probably not enough. So you probably have to step up your medical management, or you have to look at other possibilities like surgical management. And looking at the optic disc for an optic disc hemorrhage is very, very important in all your glaucoma follow-up patients. Whether you dilate the patient or not, please look at the optic disc and look for a hemorrhage. This is an advanced field defect. Now, the moment you see this field defect, you feel it's an advanced field defect, but you look at the fixation losses and the false negative errors, you know that this is a grossly unreliable field. And with a field defect like this, it's quite unlikely to get a macular field like this, and this particular field was repeated, and this was almost normal. Again, as I mentioned before, these do not correlate with the optic disc finding. So when you have an advanced defect like that, you also expect an advanced field nerve damage in the optic nerve head, which was not there in this particular patient. So always look at the optic disc carefully once again and repeat fields whenever you are in doubt. Look at the abnormal sensitive fields. Once in a while, you need to look at the actual numbers here with sensitivities of more than 50 shown here. These are the trigger-happy patients. But before dismissing these patients as trigger-happy patients, make sure that you repeat this field. And this field, particular patient, an actual glaucoma defect has been unmasked here. What was happening here is this was very highly sensitive, and so this appeared normal. But when the sensitivity was adjusted and the field was repeated, this actually unmasks a field defect. And so at least once in a while, you have to look at the raw numbers on your perimetry chart, which might actually help you to unmask a field. There are patients who have already poor fields. You know, advanced cupping. There's no point in going on repeating these large 30-2 and 24-2 fields in such situations, because it probably does not give you any indicator as to whether this field is progressing or not. So in such situations, it's always better to do the central area fields like the 10-2 or the macula, which gives you more important inputs as to whether the patient is progressing or not. And you can also easily look for a macular split in situations where you are contemplating surgery. The isolated poor field is again another thing. This is a patient who has been doing fields quite consistently over a period of time, and one particular field, suddenly there is a drop. So the important thing to look here is, one is of course to consider that the glaucoma has worsened. Along with that, you also have to look at other situations like venous occlusions. Venous occlusions, as you all know, are much more common in glaucoma patients, and so you have to look at the fundus carefully and look for other causes of field progression. But this particular patient did not have any of this, just a bad day, bad field done, and a repeat after that again turned out to be normal. So unexplained worsening of a field, you have to look at the retina very, very carefully. Also keep in mind neurological lesions like venous occlusions, AION, etc. Now look at these two fields. On one cursory examination, this field looks to have been improved. But if you look at this very carefully, this might appear a bit silly, but these mistakes are often made. This is a 30-2 field, and this is a 10-2 field of the same patient. So this field has not improved. This is just that you are looking at the central 10 degrees of the field and not the 30 degrees of the field. So change in perimetry program, you always have to be very, very wary, and as far as possible, try to repeat the same program whenever the patient comes for follow-up. Although technically 30-2 and 24-2 are interchangeable, try and do the same program whenever the patient comes for a follow-up. Neurologic field defects are something which really confuses you once in a while. A very typical, field defect like this does not cause any confusion, but if you look at a field like this is quite confusing. This particular patient underwent cataract surgery in both eyes. First he underwent in one eye, and he said vision has got now much better, but I can't read clearly. We did the other eye. Again, the patient was having difficulty only in reading. If you check the vision, he has got 6/6 vision in both the eyes, but having difficulty in reading. And then when we asked the history, this patient had a mild stroke and caused a neurological defect. And these are, whenever you have a very clean eye post-cataract surgery, you have to do a field and also look for this history of mild strokes that they might have had, and this causes typical neurological defects. Pre-perimetric glaucomas, do they exist really? They do really exist. And you have, patients like this. You have a very subtle retinal nerve fiber layer defect here, which is visible on your red-free photograph. If you look at the field, it is absolutely normal. But if you look at the RNFL OCT, you find that there is an asymmetry here, and you can see the small OCT finding here. This patient with the retinal nerve fiber layer defect, this patient also had a thin cornea with a history of, family history of glaucoma. These patients do require treatment. On the other end of the spectrum, you have what is called a green disease, where you have absolutely normal optic nerve heads. These again due to leveling out of the, these are all finally about statistics and numbers. So when the optic nerve head thicken is leveled out over in a particular quadrant, it appears as green. But if you look, this patient had, features of glaucoma in the optic nerve head. The patient also had a field defect. So this is what is called, although the optic nerve head is absolutely green, don't dismiss it off as a normal patient. You have to look at the disc carefully and see whether this patient has glaucoma or not. So in summary, glaucoma diagnosis is actually a jigsaw puzzle. There are a lot of things that has to fit into place before you finally make the diagnosis. Do not make a decision based on a single clinical diagnostic tool. Also, although once in a while the patient might complain that you are over investigating him or things like that, you have to have, the pachymetry done, you have to do a field and probably repeat a field, and have one of the pre-perimetry tools in your hand before you make the proper diagnosis. And many of these factors have to be looked into, and in spite of all these technologies, a very careful examination of the optic nerve head on your slit lamp still remains the gold standard for diagnosis and follow-up of glaucoma.